no mudamos o nome da mama África para mama lágrima.
Hi everyone, and welcome to this webinar. My name is Charles Kwuelum, and I will be doubling as both the moderator for this event and then at the same time, one of the panelists. There is no doubt that in late 2019, much of the world was preoccupied with stories of social unrest rooted in long-standing grievances around inequalities. That was expressed through so many forms of protests and violence. In 2020, COVID-19 grabbed the spotlight, unleashing tremendous uncertainty, which also, through massive economic and social disruption, generated big increases in many types of inequality. While wealthy countries are currently increasing vaccinating their populations, access to COVID-19 vaccines in low and middle income countries are virtually non-existent. But the response to this crisis can actually shape how those tensions are addressed and whether inequalities in human development are reduced. As the global death toll surpasses 4 million at the moment, and the future yet unclear, it is only necessary and absolute that the global community embraces a responsibility for a compassionate solidarity. The world's approach to this global pandemic recovery must be multifaceted. It must be holistic. And that is the reason why, to overcome the challenges of COVID-19 global pandemic, we must approach it in totality, confronting all the disruptions created by it and collaboratively assisting each other. Just last week, for example, the African region recorded a 23% increase in mortality, according to World Health Organization. And new death counts are highest in South Africa, Zambia, and Uganda. Just this week on Monday, the United Nations lamented a dramatic worsening of world hunger as regards to last year, saying that much of that is likely connected to the pandemic. For short, 10% of the world's population are undernourished at the moment, and Africa accounts for the sharpest rise, where 22% of the people, which is about 282 million persons, are undernourished. So in today's webinar, the panelists will expose to us the shadow that this pandemic is casting and these existential inequalities and effects of COVID-19. Also, they will equip us with information to ask U.S. policymakers and government to support our values by addressing the basic needs of vulnerable communities and saving lives by supporting an equitable pandemic response. In today's webinar, you will be hearing from Paul Fast, who is the Global Health Coordinator for Mennonite Central Committee, and also from Thelma, Sadzamari, and Vurayayi, Pugeni, who are the Area Directors for Southern Central Africa and Nigeria. And then from myself, Charles Kwuelum, the Senior Legislative Associate for International Affairs at the Washington, D.C. office. Just as part of housekeeping, we will have time for questions and answers after the presentations by the panelists. At this junction, I welcome Paul Fast.
Good afternoon. Thank you, Charles. It is so good to be with all of you today. Thank you for joining us and engaging on these important issues. As Charles mentioned, my name is Paul Shetler-Fast, and I am MCC's Global Health Coordinator. So I both oversee and support our health programming around the world and serve as an internal resource to MCC during health crises like the current COVID-19 pandemic. And in my time today, I want to briefly give an update on the global COVID situation and where it's headed, discuss the deep inequalities in COVID prevention, including vaccines, treatment, and clinical outcomes, and finally discuss how all these dynamics build on existing inequalities and injustices that what we could do about it. So my key takeaways on these topics, just to give you upfront a clear picture of where I'm headed in the next 10 or 15 minutes. Number one, we have seen regional and national waves, but globally it has been a relentless spread of the virus. Variants are accelerating this transmission and eroding gains in countries that thought they had this beat. Some countries are returning to normal, where most are nowhere close to that hope. Number two, where you live is becoming the primary risk factor. Most places where MCC works have few vaccines, thin social safety nets, little ability to support prevention, weak health systems, and high mortality rates. We can stop COVID, but inequality is undermining that progress. The pandemic's risks build on existing inequalities, existing injustices within and between nations. And I want to start by acknowledging that for many of us here in North America, it's beginning to feel like at least the beginning of the end of the pandemic. Vaccination rates are relatively high and still rising. In most places, hospitalization and deaths are quite low, despite a recent uptick in cases. And we should celebrate our successes. But for many places around the world where MCC works, this is just not the case. And many communities are at the worst point that they have been in so far. And for some places, for example, in parts of Africa, that had been spared the worst, the pandemic is really just getting started as new variants begin to spread. And these are also often the places with health systems unable to test or even report a fraction of the cases, let alone treat those who need critical care. And when we zoom all the way out and we look at the scale of death caused by COVID globally, yes, there have been waves, but the big picture has been a steady march of suffering, now reaching over 4 million confirmed COVID deaths globally, and likely closer to 6 or 8 million if all were counted. And all are definitely not being counted. So when we look at places being hardest hit, we also need to take into account that testing and reporting are not equal. In most rich countries and many middle-income countries, the cases and deaths you see reported are fairly accurate, perhaps only undercounting by 25–50%. These are the places you see here in shades of blue. Now, in other places, the best data we have suggests that death counts are off by 2 to 10 times what is being reported. And this is the case in much of Africa, in South and Central Asia, Eastern Europe, some countries in the Middle East, and Southeast Asia. And as the pandemic is increasingly concentrated in exactly these places, we should be increasingly distrustful of official statistics as accurate barometers of what is happening globally. And as I mentioned, while it feels here in North America and much of the rich world like things are opening back up and we're seeing at least the beginning of the end, in many places, we are currently seeing cases and deaths approaching the worst they have ever been. This week has seen the highest ever reported cases in the Western Pacific region. That's driven particularly by what is happening in Indonesia right now, as well as across the Africa region. And much of this relentless spread, including into areas that thought they were over the worst of it, it's driven by new variants that are more transmissible and in some cases more deadly. Now, these maps are from the WHO this week, showing the global spread of the 4 major variants of concern. And the one driving most of the new surge is the Delta variant. It's shown here in purple at the bottom right. It is also likely already spread across most, if not all, of Africa. It just hasn't been picked up in many countries due to lack of capacity to sequence the virus in every country. Delta is roughly twice as transmissible as the original virus we were dealing with last year, and far more transmissible than any of the other variants detected so far. This is why it has traveled the world so quickly, after first being discovered in India during their recent surge, and why all the precautions that had worked for so long, at great cost in many places, have now failed. Double the transmissibility means that the measures that used to suppress the transmission last year no longer work as well. And while the vaccines are continuing to hold, their efficacy has been somewhat reduced. It is extremely dangerous to let the virus continue to spread so rapidly as new variants continue to emerge. Now, the best measures we have to stop the virus are all in prevention. Masks and social distancing can go a long way, but vaccines are our best way out of this. But unfortunately, we have a long way to go globally. This is a map of global vaccination rates. And for many places, just getting started with vaccines, for example, in most of Africa, it may be years before they reach the same rates of vaccination that we have today in the US or Canada. And you may notice on this map that the places without vaccines are also generally the same places that MCC works. They tend to be poorer countries with weaker governments, weaker health systems, weaker social protections. Importantly, they're also places with higher risk of conflict, natural disasters, and displacement, which all compound. These are also places less able to put in place other prevention measures. Weak social safety nets and vulnerable populations do not allow for strict or prolonged lockdowns. Many people do not even have access to clean water for hand washing, let alone hand sanitizers and disposable masks. Physical distancing, taking days off work, these are luxuries most of the world just can't afford. And now these are the same places facing COVID without the protection that we know vaccines can offer. Only 1% of people living in low-income countries have received a vaccine dose. Now, as a point of comparison, in the United States, we achieved a 1% vaccination dose by the end of December 2020, 3 weeks after the first vaccine received emergency use authorization. So while in the US and many wealthy countries, we have open access to vaccines and are struggling to even use the doses we have, we're hosting million-dollar lotteries to convince people to be vaccinated. Most middle-income countries likely will not achieve majority coverage that's necessary to slow transmission until late 2022. And most low-income countries may not get there until 2023 under current projections. And the reason for this is simple. Those who can afford it have bought up all the early supply and are hoarding it. Yes, things have gotten a little better recently on paper. The US is now the biggest donor to COVAX. That's the UN way of sharing vaccine doses, both in terms of promised doses and dollars. But it is not nearly enough, and it is coming way too late. The graph on the left here shows that the vast majority of doses have been bought up by richer countries. And even the amounts shown for COVAX, that's the UN system here in gray, or the low and middle income countries, are overstating their supply, since they're generally further back in the supply chain, even if on paper they've secured doses. So when push comes to shove, the higher bidder is always winning. If places like the US and Europe start giving booster doses, a third dose, as Israel has recently started doing, that will push low-income countries once again even further back in line. Now, the graph on the right is even more startling. The WHO, the World Health Organization, reported this week that we actually have enough doses in the world today, available approved doses sitting on shelves today, to fully vaccinate every healthcare worker and every high-risk person on Earth. And we are expected to have enough doses to reach 70 or 80% coverage globally this year. We may choose not to do it, but we can. We are choosing this level of vast inequity in vaccines and ability to prevent disease. And sadly, this inequity mirrors existing inequities in the capacity of healthcare systems to respond if you do get sick. This is a map showing the distribution of critical care hospital beds around the world. Now, some countries where we work have 0 ICU beds that would be appropriate to take care of the sickest COVID patients. And so, not surprisingly, if someone does get sick with COVID, their chances of dying are not equal around the world. In the US, things have gotten much better since the early days of the pandemic, and your chance of dying of COVID, if you're unvaccinated, are still less than 2% for the average person. But in some middle-income countries, like Mexico next door to us, that rate is closer to 10%, 5 times higher. And it is many times higher than that for patients needing hospital care in places like Haiti or Burundi or South Sudan, where ICU beds are few and far between. at every level, from prevention to treatment to clinical outcomes and follow-on effects like hunger that Charles was mentioning. COVID is compounding and building on existing inequalities. As the rich world vaccinates itself and hoards resources, we are creating a two-tier pandemic, with risk increasingly concentrated in exactly the places least prepared, least able to respond, and least able to afford it. One example of this that I know well is Haiti, which has been in the news recently, and where I and my family spent 5 years returning to the US just before the pandemic started. Haiti was already one of the most vulnerable places in the world, with high rates of poverty and hunger, extreme vulnerability to natural disasters, chronic political instability, weak health systems, and social safety nets. And now, in the midst of COVID, not a single vaccine has been administered. Cases have been surging right alongside the political chaos, with little ability for everyday people to take precautions, no ability to get vaccinated, even if you want it, extremely limited medical infrastructure at the best of times, and so very poor chances of recovery if you do get sick and end up needing intensive care. And if we in the US wanted to, if we cared as a country, we could change that. If the US were to donate just the number of doses we waste in this country in 3 days, we could bring Haiti up to the same vaccination rate that we have in the US today, protecting every health worker and high-risk individual and dramatically slowing the spread. Not acting now in places like Haiti, it's a political choice, and it's costing lives. We could protect every healthcare worker around the world today if we chose to. Nurses like Vurayayi, who's pictured here, serving in an MCC-supported clinic for displaced people in Eastern Congo, are working every day on the front lines of this pandemic. There is no ICU bed for Vurayayi or her patients if they were to get sick and need it. She does everything she can to protect herself and her patients. She's ready to be vaccinated, but she can't. We could change that today as a global community or as a country if we chose to. The fact that we don't is simply wrong. I was in Congo in May to train health workers like Vurayayi on COVID prevention and how to build vaccine confidence for when those doses do arrive. And while I was there, the volcano outside Goma erupted. You may have seen it on the news, forcing 400,000 people, including myself and our MCC team, to evacuate. People fled in the night, mostly on foot, carrying what they could and desperately trying to hold on to loved ones in the chaos. In the weeks following that mass displacement, cases of COVID rose 31 times in the surrounding area. Suffering builds on suffering, and COVID is just one of many problems these communities face. But we could end much of that suffering of COVID by vaccinating every high-risk person around the world now. We could probably end the pandemic this year still if we simply shared resources. Allowing people to continue to die at this point of COVID is a political choice. Thank you.
Thank you, Paul, Pugeni, and Thelma.
Please give us a minute as we share our presentation. Thank you, Paul, for your presentation on the global perspective. Today, Thelma and I are going to talk about the vaccine inequalities in our region. As Charles said, we are the area directors for South and Central Africa and Nigeria. We are based here in Kigali, and we see it firsthand every day what happens in this region. This region covers about 8 countries: the Democratic Republic of Congo, Rwanda, Burundi, Malawi, Zambia, Zimbabwe, Mozambique. Basically what we do is to manage and oversee MCC programs in this region. So we do have the first-hand experience of what is going on. Perhaps before we dive into our presentation, we want to take a moment to do a reflection.
So like Pugeni said, before we talk about COVID inequalities and how they have played out in our context here in Africa, particularly in our region, we would like to highlight the following. Firstly, that Africans are susceptible to 3 big killer diseases on the continent, and that is malaria, tuberculosis, HIV, and AIDS. And that globally, 50% of children under 5 who die of pneumonia, diarrhea, measles, HIV, tuberculosis, and malaria are in Africa. I would just like us to take a minute to just pause and reflect on that before we move forward.
So, what are some of the impacts of COVID-19 in our region? We have classified these impacts into social impacts, health impacts, economic impacts, disruption of the much needed and valuable indigenous knowledge systems that have sustained the continent and our region for such a long time, increase in gender-based violence and mental health issues. Education has been disrupted, and of course, there's been a lot of conflict as a result of COVID. When you think of what Paul mentioned and look at some of these impacts, you can already see that Africa suffering, the region's suffering, is not just going to end in the region. The echoes of this suffering is going to be global. The echoes of this suffering is going to be political, not at country level, but at global level. When health systems are affected and economic systems are affected in our region and in Africa in general, in a world that has chosen globalization as a world order, I definitely can assure you that the impacts are going to be felt even in America, where you have all the vaccines, even in Europe, where you have got stashes and stashes of vaccines, let alone in China and perhaps in Russia. We know that disruption of indigenous knowledge systems may seem to be unique to Africa, but we also know that even in America, even in Canada, indigenous communities are suffering the wrath of COVID-19 because of our lack of attention and preparedness to help them. The same is true for Africa. Because of COVID-19, women and girls suffer the most from gender-based violence due to serious and excessive lockdown and restriction measures. As I talk right now, Rwanda has announced a total lockdown that starts on the 17th of July. They've announced that they will not even allow ordering food online or delivery through takeout arrangements. So what this does is that people are locked inside their houses. There's tremendous stress for couples in abusive relationships. That is really torture. That results in a lot of mental health issues and gender-based violence. But really, as Paul once said to me, do we really talk of mental health issues in Africa? Is it even a priority? Do we even think of the depth of the impact of COVID on ourselves as individuals, our neighbors, and even those countries that we relate with, like here in Africa? Do we even think about how terrible and challenging it could be when people lose their informal jobs that they use every day to get money to put food on the table? We are talking of people who have no insurance. We are talking of people who do not have a pension scheme or plan. We are talking of people who don't have any other social safety net to protect them when they lose their informal livelihoods. So as we think about the inequalities in COVID distribution, let's think about the depth and breadth and even the pain that these have, not only to the adults that normally come on TV and say a few statements, but to the children that are in those houses that have little or no voices. Currently in Rwanda, the education system is just about to be closed. The government is doing everything it can to protect the students that are in class or that are trying to write examinations, but because of the rise in cases, there is no way out. They have to do something to help the situation calm better, in better ways. But what else can they do other than social distancing, using a mask, and also perhaps looking at other options? This is quite sad for us, because when we think of what happened last week when the Euro 2020 games were being played, we saw 67,000 people in Wimbledon coming to watch the soccer match. No masks, no social distancing, singing, enjoying themselves. Is this the world we want to see, where others are enjoying and others are suffering? So perhaps one of the biggest questions that we thought we could share with you, which is perhaps a glimpse of hope, perhaps something that even as governments and as individuals and as companies or organizations, faith communities, we can also think about. MCC is working by adapting ways of working so we can keep our staff and partners and communities that we support safe. We are also supporting health and WASH work by making sure that we collaborate with the Ministry of Health. We mainstream COVID prevention and awareness in all programs that we implement, and Paul Fast is our global health coordinator assisting us with that. We also make sure that we invest in infrastructure development, such as construction of isolation centers in Zimbabwe and Zambia as an example. This is what MCC is doing. What more can the American government do? Definitely they could do more. We also work to provide PPE materials, supporting food security, peace building, and education projects to bolster community resilience. We do awareness raising through mobile text messages, radios, and other safer ways that can enable us to reach out to a broader audience. We also talk about issues. This is why today we are so proud to be part of this. To say these are just a few examples of what MCC is doing. And when you look at these examples, you can see that as governments, America could really be the champion and could be the leader in trying to give a better way of responding to these issues by making sure that vaccines are accessible, people are safe, people can go back to work, and everybody can have a livelihood and a decent life with dignity. I would like to share a brief story about the new ways that we are reaching to those vulnerable people affected by COVID in Africa. We are leveraging the use of technology, and in this case, we have used cell phones to reach out to many people that have been affected by lockdowns, also by the COVID pandemic. Paul spoke about how infectious the new variant is. He spoke about how the numbers are escalating. As MCC, we continue to seek innovative ways to reach out to people with the much needed awareness-raising information and education. Smartphones, basic phones are being used to reach out to communities. To the far right, you see the picture there of a lady with colorful beads. That is Namchura, who is from Kenya in the Turkana region. These are pastoralists who survive by moving with their goats from one place to the other in a semi-arid area that is dry, and in most cases where meat is their staple food because they cannot produce any crops. MCC had to be innovative to reach people like Namchura with the much needed assistance during this time of the pandemic. And what did MCC do? They introduced a program that actually put bank cards in the hands of women like Namchura, and money is transferred electronically to her so that she can buy her basic needs, hygiene needs, as well as PPE material.
As has already been mentioned by Charles, Paul, and Pugeni, COVID is just one of the many challenges that we are facing here in Africa. A lot of the people here are already living with pre-existing conditions such as HIV and diabetes, malnutrition. And we can only imagine what tomorrow will look like the longer we go without vaccines. And as we all know, poor countries typically do not have infrastructure that would allow for good access to healthcare. So poor access to healthcare remains a big challenge that we have. And still in the midst of all of that, we also have some natural disasters sometimes, like the volcanic eruption that happened in the DR Congo. You will see in the picture Paul first, who is here with us, standing with Molanda Jimmy Juma, our representative for the DRC. And in the midst of that all is also government policy aiding and increasing and compounding the effects of COVID in our communities. The strategy the international community has also used, as well as the communication on COVID vaccine and COVID rollout, has also not helped, especially here in Africa. People continue to wonder, what does it mean when we hear that if you have a certain type of a vaccine, you're not considered vaccinated in certain countries? Which vaccine would be best for me to take? But does it even matter because we don't even have access to the vaccine in the first place? Should it even be a question we think about when there is nothing in the horizon?
Well, and when all this happens, when all these compounding factors come together, we do see dangers of immunity inequality in our region. The first being loss of life. We spoke about the economic impact on economies of poor countries. The richer gets stronger and the poor gets poorer and weaker. Deep distrust, as Thelma said, because of communication strategies, the rollout plans, and the selfishness and greedy of those that have resources. History will tell us that indigenous communities and Africans, or the Black community in general, have never had a fair shot at anything that could save life, be it vaccines. They are always prioritized last. That is not healthy, because that only builds a lot of distrust. People become suspicious. Even when people are trying to do something good, people look back at history, and history is not good. I totally believe that the American government can this year do something about this and transform the distrust that is building up in Africa, particularly in our region, into strong bonds of trust, friendship, fellowship, and good international relationships. We also see the other danger being the widening racial health inequalities, disruption of global markets, as we have said, and of course, the moral question. How do you feel when you are able to feed your family and have a lot to spare and your neighbor is hungry? How would you feel when you have enough to vaccinate, when you have enough to even sponsor very expensive campaigns for everyone to get vaccinated, when poor countries that are looking at you for leadership, that are looking at you for example and standard, that think you are the oldest democracy to ever exist, that think you are a role model, and you can't even just share the little vaccines that you have. We have heard the World Health Organization Director General asking, he is just like the voice in the wilderness, appealing to all the rich countries to do something about this thing. America, Canada, Europe, we have a moral question here. Let's sit down and talk. Who are we? Let's look in the mirror and face ourselves. Please, if you are listening to this conversation, wherever you are, my intention is not for people to feel guilty. I am not angry, but I'm really trying to raise an obvious question. Do we really want the world to be this way? because of the vaccine inequality. Today, as we talk, a 5-year-old that is malnourished has just lost a parent to COVID, and the parent was their only source of livelihood. What is their tomorrow like? Should we continue to stash, keep, produce, and protect those vaccines for ourselves? Let's talk about the perspectives on vaccine hesitance. I know a lot of you read in the paper some of the stories out of Africa, and perhaps as I was talking, a lot of you were like, no, but even Africans do not like those vaccines too. Yes, let's talk about that. From our region, we hear that the messaging by the international community has left people confused. That is one of the reasons why there is hesitancy on vaccines. The rollout process of vaccines has not been really good enough to instill confidence. For example, the 3-tier system and the approval system of certain vaccines have left Africans wondering and confused. The certification process is also another big issue. As an example, the US does not pay attention to the Chinese and Russian vaccines, yet those are the vaccines that are available in Africa. Most African countries look up to the US for leadership. And this is why I'm excited to be talking today to a US audience. You are the leaders here. You are the role models. Take your chair, sit on the chair comfortably, and please come claim your position. We need you here. When the Chinese vaccines and the Russian vaccines come without a US certification, people are doubtful. Our understanding so far is that the World Health Organization is paying attention to those vaccines, but the US is not. We want to encourage the US to either pay attention or give us Pfizer, Moderna, Johnson & Johnson if they don't pay attention. People question the efficacy or effectiveness of vaccines. We have seen over and over again on the media how people talk about some of the negative impacts and sometimes halt the distribution of vaccines. While that is definitely important, it can also raise some hesitancy, especially to those people who are far removed from the information and the communication strategies. We also have got myths and misconceptions in Africa. People have a lot of myths and misconceptions, and some people also rely on historical information that may sometimes not be accurate. This is why we are calling the American government to do something about this. It is a really strong window of opportunity for the government to correct some of these things and to take leadership, as I have said, and to demonstrate that indeed America is the strongest and powerful nation in the world. We also have got fake news. Then we also have got discriminatory treatment from the past, logistical storage, and expiry date challenges. So those are some of the factors that we see as affecting hesitancy as affecting vaccine uptake here in our region.
Well, thank you very much. We will pass it over to Charles now.
Thank you, Thelma and Pugeni and Paul as well for thank you, Pugeni, Thelma and Paul for your layout. That's great. That gives me an insight. What happened? Can't find mine. So this. Yeah, this in a way gives a room for us to build the argumentative narrative, which is all about the fact that one, all that Paul, Thelma, and Pugeni have said boil down to the fact that first and foremost, there is the need for us to present the ontological and human dignity argument. We know that in Genesis, the divine God made man in his own image and likeness. And so what it means and what it implies in our own faith as Christians is the fact that all humans, irrespective of your color, your creed, your geography, everything about you, all of us share from that undiluted dignity and beauty which God has blessed us with, and that is human dignity. And so, in a way, what it means is that whether we like it or not, in fact, we are all interconnected. So we are all weaved into one, and that is God's intention. And going from this ontological argument, however, we are made to understand that we are precious and special in the eyes of God. And so because we are interconnected, in Psalm 8, for example, the psalmist makes us to understand that we human beings are actually exceptional, even though we are mortals, but God's regard for us is such that he has crowned us with glory and honor. So people faced with inequalities, and for us who are privileged, we all share the same human dignity. And then when we talk about, for example, sustaining MCC's mission and our Anabaptist confession as Anabaptists, for example, you and I know that we have been called as Christians and as followers of Jesus Christ to share God's love and compassion to all by responding to basic needs and working for peace and justice. And this, in a nutshell, inspires and motivates us in a way and our vision for communities and in fact a world in right relationship with God and with one another, and even also with the ecosystem. So this is our confession and we have to live by it. And that is the reason why we see this argument as being very, very foundational to you and I who are Christians and more so Anabaptists. And what about the facts laid before us? Paul, Pugeni, and Thelma have laid out the many devastations, the growing variants, and the increased needs, be it around food insecurity, be it about economy, which we know now that the World Bank made us to understand that COVID-19, for example, has led to a reset of the world's progress over poverty. And so now, for every 1% of decline in poverty, the world slowly grows by 2%. So what it means is that definitely we're all, the whole development gains that have been realized in the past are now reduced or in a way moved to the background. And so there is a vacuum. What about vaccine apathy and discrimination and injustice? You and I know that the money that was used to fund the research for COVID-19 vaccines was actually money from us, the taxpayers. So the taxes we paid was what was used to fund this research. And you and I know that your intention and my intention to support the research of these vaccines is not for monopoly. We wanted a situation whereby, since you and I have prayed for God's wisdom and for knowledge, for innovative cure and therapeutics. Remember that when COVID hit, we all were on our knees and praying and asking God for human wisdom and for knowledge in order to discover innovative cure and therapeutics. Now it has been discovered. We want these cure and therapeutics to be shared, especially the vaccine. And that leads us to the fact that there is no need for us to dominate or control the production of vaccines, the distribution of vaccines, and even deciding those who are supposed to receive these vaccines, since they are life-saving. However, we are made to understand that health itself is a human right issue. Health is not a privilege. And that is the reason why, from a moral perspective, I know that Thelma and Pugeni mentioned that, but the fact still remains that even in the scriptures, God himself healed men and women when Jesus moved around doing good. So through Jesus, he made health, good health and well-being accessible to all. And it's the same thing even in the Old Testament. He said, be still and know that I am God, for I have come to take away your infirmities. And so again, what about the social and self-interest argument? It's simple. If everyone around us is not safe, we are not safe. And what it means then again is, if in the US we have invested heavily to be vaccinated, and then people outside the US do not have access to these vaccines, what it means is this: there is no way international trade can flourish from the US to the outside world, because COVID-19 brought even about restriction of movements of goods and persons. And so we know that the global institutions have actually stylistically actually categorized nations. And I know that Paul did mention this, and then also Thelma and Pugeni. The fact that the UN, for example, the World Bank and the IMF, they have categorized nations. And so we know those nations that are either low-income countries or middle-income countries. And I know that Paul did display this map, but just look at this map closely, this atlas. Now, Paul mentioned that low-income countries and middle-income countries are those countries where MCC has historical presence. And that is the fact. A very great, massive part of Africa and then even Asia, for example. And we are made to understand that these middle-income countries are home to 75% of the world's population and 62% of the world's poor. Africa is part of it as a continent. And some countries in Asia are part of this. And then we are also made to understand, for example, I know Paul did display the vaccination charts. Let me just go quickly to share with you this chart. So as of today, we are made to understand that the US has actually attained 66% of its population fully vaccinated. If you look at this chart before you, when you see the names of these countries that have had access to vaccines in such a way that they can say to the world that, hey, look, a very good number of our populations are vaccinated. Do you see the name of any middle-income country or low-income country where MCC is historically present? No. This is vaccine inequality. And that is what we are talking about. The fact that the big pharma that was supported by our taxpayers' money to do research on these vaccines, and then for these vaccines to be made available, alongside even the knowledge for the production of these vaccines, for the fact that they continue to hold that, and the fact that they continue to control it, implies vaccine appetite. And apart from that, we are made to understand that even as a whole, I know Paul alluded to this, but as a whole, low-income countries, those vaccinated, are slightly currently above 1%. Slightly above 1%, which is very, very frightening. And so what it means is that if these countries you see in these colors, the dark colors, across Africa and Asia, they are the ones that have received a little bit above 1%. If these countries remain this way, then what it means is that at the end of the day, if there is no access to COVID-19 vaccines, MCC's mission and vision, and our mission as Anabaptists, our confession will be adversely affected. And that will put before us a guilt, as if we were just looking, seeing policymakers deciding and not prioritizing our values. It would then appear as if we are complicit, but actually we are not. And so the facts before us, my fellow panelists have mentioned the issue of global inequalities. So the response to these shocks are entirely different and they vary. The US has the capacities and they have the resources And that is the reason why the U.S. can now pride itself of bouncing back. And then the moral question, which Thelma and Pugeni did throw before us. How do we feel when we are bouncing back and others are not bouncing back as results of human negligence? What about the fact that developmental gains and humanitarian gains are being obstructed? Pugeni and Thelma did mention the fact that at a point in time, there was a kind of shift from our usual traditional way of doing our work. But however, I know that there was a pause, and that pause actually disrupted the flow of the gains, which MCC, a ministry of Anabaptist churches, could tell its constituent members that, yes, these were our gains. But COVID-19 disrupted that. And food insecurity, it is there. Because of austere lockdowns, it disrupted food systems, production, distribution, storage, delivery. And then worse still, it caused a spike in price. And that is the reason why in most countries, even here in the US, I know we still feel the pinch of that inflation, of the increase in price for some of these food items. But in those middle-income countries and low-income countries, it is difficult for a common Nigerian, for example, to go and get the meal that he or she was able to get even prior to COVID or even when COVID started initially. And then what about healthcare inadequacies? Paul and Thelma and Pugeni did mention that. I will not repeat. But however, again, the issue of violence and conflict, it continues to grow. It continues to escalate. It is real. When people are hungry, they are angry. And so when they are angry, they don't trust the systems anymore. And since they don't trust the systems and institutions anymore, they react. This is normal. And then natural disasters. Paul, Pugeni and Thelma did mention that in the region. And we know that last year, there was an infestation of crop destroying locusts in East Africa, the Arabian Peninsula, and some portions of Western and Southern and Southwest Asia. And then economic downturn that I have mentioned. So that is to say that to tackle COVID, we must go beyond access to vaccine, actually, to make it holistic, so that resources devoted to access to vaccine, for example, will not be diverted or will not be channeled towards issues like food, issues like economy, and then issues like rebuilding people and communities as well. And that is the reason why the issue of forced migration is real. So during COVID, people were actually repressed by governments. And because they were repressed, they had to flee when it was assumed that COVID had stopped. And even currently, people are still migrating. And that is the reason why the flow and increase in migration will continue. And I know that the area directors alluded to the fact of mental health issues and psychosocial support. For someone who has been under tremendous and horrific situation, that person faces, aside from bodily ill health, the person faces psychological ill health. I know that in many parts of the world, mental health is regarded as a taboo, but it is a reality. And so the need for psychosocial support is actually increasing. And we know that MCC has a niche when it comes to issues of psychosocial support. Today, the World Bank and IMF and the UN make us to understand that millions of people are faced with poverty and global inequality, food insecurity. And with this, it means that there is an economic downturn. Now, in Africa, I know that Pugeni had mentioned that Rwanda is currently under lockdown. Now, places like Tunisia, Uganda, places like Zimbabwe, places like South Africa, places like Senegal, for example, and Sierra Leone and Namibia, we see the Delta variant attacking and destroying, and currently it has gone into Nigeria. Now, what are the next steps? I would say that this is the time for us to express a compassionate solidarity, and that calls for a holistic global intervention and collaboration. And I call this the new world order. First and foremost, the U.S. government each year allots 1% of its federal budget to international assistance. I know that if I had not mentioned 1% now, and I ask you US-based MCC constituents, how much do you think, or how much percent do you think the US government gives in a year to support countries in need? I know you would say either 25% or 30% or so huge an amount, but unfortunately, it's just 1%. And then less than 1% goes to poverty-focused development assistance. And poverty-focused development assistance relates to those accounts that tend to fund those programs that MCC also supports on your behalf and with you. And so at this time of the year, we are facing budget season. And so it is going on now. Your public officials, your members of Congress, the representatives and the senators, they are currently trying to earmark and to vote the amount of money that goes to assisting nations in need. They are trying to decide what percent of your tax money, what percent of my tax money goes into supporting these nations in need, the vulnerable nations. Now, we are called to ask our public officials to support a robust funding for FY 2022 for this budget. And then what about supporting the authorization of a robust special drawing rights? Remember the economic downturn, for example, which nations are faced with poverty. So for these countries to actually bounce back, for these countries to develop the capacity, for these countries to have the resources in order to tackle issues of food insecurity, to tackle the issues of unemployment, the issues of social safety nets, the issues of health infrastructures, for example, and then other humanitarian needs. There is the need for the US government, who is a global leader and one of the greatest stakeholders in IMF, to ask and support the IMF to release a robust value, which is 2 trillion SDRs. But in the Congress at the moment, there is an opposition. Some ask that the US government should not support the money to be approved. And this is free money. It is not our taxpayers' money. The IMF has a mechanism that its members will have access to these funds and to this money when they are released. And then also, we are asked to influence our policymakers to support, for example, a bill that calls to access to COVID-19 vaccines that includes mass production and deployment and affordability. It's called the Novit Act. And then also, we are made to ask members of Congress to also support a bill on mental health and psychosocial support. And just to say that the MCC Washington, D.C. office was actually part of the drafting of some of these bills, especially the one that has to do with COVID-19 vaccine access and the one that has to do with SDRs, alongside even the mental health and psychosocial support bills. I would say that unvaccinated populations anywhere raise the risk of every variance emerging and undermining progress everywhere and inflicting harm on the global economy. We are not safe until everyone is safe. Finally, I would say also that there is a need for us to support and influence the US government to support the waiver at the World Trade Organization for TRIPS, which is the release of their intellectual property rights. Now, the administration announced earlier that they were going to support it, but we want them to remain committed and for them to advocate on behalf of other nations and to try to influence European nations, for example, especially Germany, for example. Today, the Prime Minister for Germany is in the US. So it would be good if the US government can influence such stakeholders to allow the temporary release of this knowledge and information for production of COVID-19 vaccines and therapeutics alongside PPE. And we do know that this will go beyond the issue of vaccine diplomacy, which currently we are doing. The US government is donating vaccines to nations directly. Yes, it is good, but however, there is a need for a common pool so that all nations will have access and equity to those vaccines when available. And then also finally, as MCC, as Anabaptists, as Christians, you and I are called to support the work that MCC does. So you can donate and support MCC's work. Remember that Pugeni and Thelma mentioned those work that we do in the region. I will just leave it at that and then wait for questions. So, Kirsten, do we have questions?
Yes, we do. And I think, Charles, if you could just stop sharing your screen, that would be great. Okay. Yeah, first question from somebody who's posting this anonymously. So this situation looks grim. There are obviously equity and justice issues, but Americans as a whole are rarely mobilized to move for altruistic reasons. Is there a self-serving argument, reason that would help Americans care more about this issue?
So I can start there from a health perspective. There's a lot of great reasons. Early on when we were vaccinating, you could make the argument that as a country, the government's first priority is to its own people and it's going to prioritize its own people. There could be an argument for that. At this point, we have more than enough vaccine in the United States for everyone who wants it to be able to get it. Continuing to hoard vaccines, continuing to not share in the US, Canada, Europe, other wealthier countries. What that means is that there are millions and millions of unvaccinated, unprotected people around the world. And there are unvaccinated people in our own communities who continue to remain at very high risk for it spreading. And that is exactly where these variants come from. So far, most of the variants have not significantly challenged the vaccines that we have here in the US. But that may not always be the case. If this continues to burn around the world and you have millions of people infected, particularly immunocompromised people, that's where a lot of the variants happen, where the virus lives for a long time. People on with HIV, for example, would be immunocompromised, more likely to have variants develop in them. That only increases the chance that you get more and more transmissible, potentially more deadly variants coming back to the US, potentially even ones that can evade the vaccines that we have. So we have the ability to stop this. It doesn't hurt our ability to protect our own if that's what people are concerned with, and then it could keep it from posing a risk down the road. So from a health perspective, there is every good selfish reason to share.
Thank you, Paul. We have another question from Chindo Nondalem. And this person writes, Pugeni in his presentation under the headings of Perspective on Vaccine Hesitancy pointed out fake news, myths, and misconception. This is very true of scary news and myths that is making the rounds. Let me narrow it down to my country, Nigeria. There are viral videos of people who got the vaccine, but when a light bulb is placed on the spot where they got the jab, it lights up the bulbs. And in some of the videos, if a metal is placed on the spot where they get injected, the spot becomes magnetic. How can we convince people that such videos are fake when they can see bulbs bringing light and metal sticking to those spots? Pugeni and Thelma, would you like to talk about this, the fake news and how that can be addressed?
Well, thank you so much for that question. I think that a majority of time, fake news or inaccurate information is because of the fact that people do not have access to correct information. So the best way to address that is to make sure that people have accurate information, not only accurate information, but timely information, because with COVID, things move. You know, we started without vaccines. Now we have vaccines, and now we have many more different types of vaccines. So we need to make sure that people have accurate information. And when you look at what MCC is doing in some of its projects, they are actually using mobile cell phones, as I've showed, the basic ones, the phone ones, to try and counter that fake news, to try and really bring accurate and factual information to people. The other challenge for Africa is that more often people neglect the indigenous knowledge systems. These are the systems that are really powerful in terms of promoting primary health. The people that are in the community themselves, because the model of life is based on communal relationships. People like to go to their prophets, people like to go to their sangomas, people like to go, because the modern health system is expensive for people. Sometimes the hospitals are far away. So we also want to coordinate and work collectively with the indigenous knowledge bearers and those that are the power holders of the traditional systems to make sure that this information is cascaded. And this is where MCC has a strong upper hand, because the model that MCC uses to do programs is through a partnership model. And normally they use the partners that are already existing in that particular community. So they use indigenous people from those communities who are the partners to transfer the aid or the support that communities need. And when you use such kind of infrastructure, there is a high likelihood that you can counter fake news. And for sure, you can also provide life-saving information in a timeless way. Not only does it only do that, it also supports those institutions that will be in existence even way after the aid has been completely finished in terms of programming. Those structures will exist in those communities forever. And that is why I think when you do a COVID prevention program through MCC, there is a sustainability aspect, there is a stewardship aspect, and of course, there is a community resilience building aspect.
Thank you, Pugeni. Kind of a follow-up question. I think you've answered part of this, but also coming from an anonymous attendee. Thanks to the excellent panelists, particularly Thelma and Pugeni. Firstly, a link to African success stories, which I'll put this link into the chat. While the reality is inequity in terms of vaccine production and distribution, what is MCC's view of situations where alternative methods of prevention and treatment are successful? I believe that in most of our societies, these exist and should be promoted. It seems like in the quote unquote advanced world, we are being set up to be caught in the web of never-ending boosters, only benefiting big pharmaceutical companies. Is that the answer? Finally, it is time to stop looking to the U.S. as a role model. We are independent. Instead, let us, Global South, look to collaboration and building our own capacities. We can do it. I would open this up to any of you to share.
I could start and building on it. It was something that Thelma and Pugeni talked about in their presentation, was working, and they just mentioned again, this working with traditional healers, with traditional knowledge systems. That's incredibly important. Most of the global health infrastructure that exists in poorer countries was built during the colonial era for the purpose of advancing the colonial agenda. There are very good reasons why people in poorer countries or marginalized people in wealthier countries distrust the global health establishment. There's very good reasons for that distrust. And so you hear that, I think, in this person's comment about, you know, what is really the benefit of these models that are being promoted? You know, is this really just for the benefit of big pharma? For the big pharmaceutical companies making profit. And the sad reality is people have a lot to be skeptical of. And yes, pharmaceutical companies are making a lot of money on this. And that does not help with any of these trust issues. That does not help with building confidence. It doesn't help with sharing resources. And so we want to acknowledge the problems in our global health infrastructure, get what is useful. You know, some of these vaccines are very useful. And so even if we don't trust the big pharmaceutical companies, even if people don't trust the WHO, that doesn't mean that all these vaccines are not going to be useful. So take what is useful, have honest conversations with people, look to techniques locally, to local leaders. There is a ton of knowledge there about what works in the much broader scope than just the tiny biological question of what's going to stop this virus. What's going to support people slowly? You know, one of the reasons people don't want to go to healthcare systems is a lot of these healthcare systems are very dehumanizing. They're not good places to be. They're not places where one's dignity is valued and where one's cultural and your identity is respected. And so people look to more holistic healing systems, I think, for good reason. And so in Zimbabwe, there is a beautiful project there working where we're working with local indigenous healing systems and traditional leaders to be partners in this. You know, what works from all that is available, and being respectful of the choices people make in terms of their healthcare, trying to promote true, accurate, timely information, like Pugeni and Thelma were saying, and then also doing that in a way where we are coming to the table as partners with the community to achieve their goals. Not there to promote Pfizer's agenda, but there to promote the community's agenda. And what do they want? What do they need? And how can we help them get there?
Yeah, thank you, Paul. I want to speak to the other part of the question about self-reliance and independence. You see, during my presentation, I made mention of the fact that for a holistic approach, we will have to go beyond just COVID-19 vaccines to other aspects. But again, from all the presentations, the issues of existential inequality, lack of resources, for example, capacities, actually are laid out. But however, our advocacy's aim is for self-reliance in such a way that those vulnerable nations and low-income countries, for example, who actually have the innate capacities but lack other resources that will enable them to be involved in the physical production of those vaccines, for example, and also in order to recover from those shocks that COVID-19 mounted upon them. That is the reason why we are asking that, aside from the US government, for example, asking and influencing European countries, for example, and other nations who are part of the WTO, who are refusing permission, a release of information in relation to the production of these vaccines, for example, we are asking that the US government should influence them to actually ask for the release of that information, so that there is a pool of knowledge where people can actually go to, most especially those countries that have the capacities already. Remember, the HIV/AIDS era, for example, at a point in time, it was like this. There was a monopoly. Many deaths ensued. And what happened? By the time there was a temporary release of intellectual property rights, that was when African nations and other nations were able to mass produce those vaccines and therapeutics, and that were used to mitigate the hazards of HIV/AIDS. So that is the scenario before us. We want them to see this as a template and now grant that release, but yet they are refusing. Then secondly, we talked about the special drawing rights. The IMF previously, I think in the 1990s, when there was a global economic shock, the IMF designed the global reserve for its partners, for its members. So any member of IMF as a nation would have access to that free money, that free value of money in proportion to your membership. So currently, as of last week, the executive board of IMF has approved $650 billion US worth of special drawing rights. But in Congress, we have worked with two offices to initiate and introduce a bill that recommends the IMF to release $2 trillion worth of SDRs, recognizing the fact that the needs are growing. They are growing. And because they are growing disproportionately, that is the reason why we are asking that more be released. But yes, we have stakeholders there in Congress who are saying, no, it is too much. Why? Because they fear that some nations who are members of IMF that don't need that money will actually have access to that money. And that poor nations who have been borrowing will actually use that money to pay off their loans and stuff like that. So we're talking about self-reliance, we're talking about self-independence, but you know that behind the scene is this issue of exploitation that has been going on even before now. They've been plundered. So, and then again, we are asking that mental health and psychosocial support programming, for example, be supported in Congress, so that in all international assistance programs by the US, we will have those programs being funded. I'll just leave it at that.
Yeah, and I think I will briefly just say that I really liked the question, the last part of the question, where the person who asked said that we have to start to collaborate as the Global South, and we have to be independent and to stand on our own. And I want to say that that is quite the perspective that I also wish for. I really wish we could see collaboration. I really wish we could see innovation hubs in the Global South. I really wish we could see our governments pulling together. So in some ways, we want to make sure that we also talk about these issues here at home as well. We talk about these issues, talking to the international community, and also talk about these issues here at home, because we do have to collaborate. We do have to come up with our own innovation hubs. We also want to be the first to come up with a vaccine whenever a disaster happens. We also want to be leaders in innovation. But for us to be able to get there, like Charles was saying, there are certain steps and foundations that we have to put in place. And we think that we can do it. And I just wanted to affirm that part to say, yes, we agree. And I think as MCC, we also believe in local capacity. We believe in sustainability and resilience building in those particular communities that we serve. We don't believe that communities we serve are helpless. We believe that they bring very important resources, and we believe that they have knowledge that needs to be affirmed and that can also be developed into useful tools that the world can benefit from.
Thank you to all three of you for those responses. I also want to share with Carol Shuttler that we will be sending an email later with information, particularly about the bills that Charles was mentioning, and also with links to the ways that you can take action. I've also posted those links in the chat, the specific actions that we have created right now, where you can write to your members of Congress related to the NOVID Act, and also to the special drawing rights and the TRIPS waiver. So I think I will hand it back over to Charles now.
Thank you, Kirsten. I want to say thank you so much to all of you who have participated in this webinar. Our thanks go to All Fast, Thelma and Pugeni, who are like Pugeni and Thelma are actually joining us from Kigali. And you know that it's actually late at night now. So we thank you tremendously for that availability and for your presence. And then to Kristen, who has actually handled our technical side of things. Thank you. And to all of you once more, thank you. And we are going to send out a follow-up email. And please, when you get this email, click on the call for action in order for you to influence your member of Congress, your public official, your senator, your representative to say, hey, look, I want you to support this because it is my value as a Christian, as an Anabaptist, to save lives and to provide the basic needs for those communities that are vulnerable, and to reconcile not only the world to God, but also the world to itself. Thank you so much for attending. Bye.